Welcome back to the Doctor is in Television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here in beautiful Monterey, California. Thank you very much for joining us. I'm delighted to have you with us, and I am delighted to welcome a very illustrious special guest to the program, Dr. Stephen Goldberg, cardiologist. Dr. Goldberg, thanks very much for being here.
Well, thank you very much for the invitation.
Dr. Goldberg, this is my opportunity to meet you more formally. You have not been here in Monterey all that long. Tell us a little bit about yourself. Where did you transfer from?
Well, I spent about 15 years at the University of Washington in Seattle, and previously I'd been in Los Angeles, and while doing my training at Cedars-Sinai, I got to know Richard Gray, and Richard called me up a year or so ago and said, did I want to come to Monterey, California and start a structural heart disease program? And I said, that sounds nice, and here I am.
Excellent. Dr. Goldberg, I appreciate you coming by, and of course we're going to try to get Dr. Gray on the program later on another segment. So Dr. Goldberg, I want to know more about cardiology. It used to be that a board-certified cardiologist, all cardiologists pretty much did the same things. And then there was interventional cardiology, and then certain cardiologists started doing catheters, and apparently now you guys are doing valves, and then there's a subspecialty of managing the electrical system, et cetera.
Right.
So tell me more about your subspecialty in cardiology.
Well, I'm an interventional cardiologist, and you mentioned that there are electrical specialists, and so I'm a plumber. I take care of the plumbing. So when the pipes are corroded, I try and fix them. When the pipes are leaking, I try and fix them. And if there's a hole someplace, I try and plug it. And that's what interventional cardiologists do. We're probably best known for putting in stents in people who have blocked coronary arteries. We open up with a balloon procedure, and to keep the artery from collapsing down, we put in a piece of metal called a stent. But more recently, we've started treating other parts of the heart besides just the arteries supplying the heart. And that discipline we've called structural heart disease. That's where we put in new valves non-surgically. We plug holes in the heart. We treat people who are born with defects of their heart or vascular system, as well as people who develop problems later on in life, as well as some conditions which is very common but only causes problems in some people. So it's kind of a variant of normal that can cause problems, and we have developed techniques to try and treat those to prevent recurrence of some of those problems.
Well, Dr. Goldberg, I just heard you say that you oftentimes will do a procedure to replace or repair a valve without doing a sternotomy incision or without going in between the ribs. That in itself is fascinating to me. I want to make some time, leave some time before the end of the segment to learn more about that.
Sure.
Dr. Goldberg, I thought it might be useful, since the heart is such a fascinating organ to me, and I think to our viewers as well, and of course to you, if we can go over the basic structural anatomy of the heart, talk about the aorta, talk about the vena cava, talk about the ventricles and the atria, et cetera, and really what the valves are. Can we start by talking about the four chambers of the heart?
Sure, but we maybe simplify it even more and say that there's parallel circuits in the heart. A heart that is the right heart, which pumps blood to the lungs, and the left heart, which pumps blood to the body. And when blood comes back to the heart, it doesn't have as much oxygen in it because it's been used by the muscles and the tissues. And it comes back through the veins and the inferior vena cava and the superior vena cava and arrives at the collecting chamber of the right atrium. That saves the blood to go into the right ventricle, which pumps the blood to the pulmonary arteries. Then the pulmonary arteries delivers the blood to where oxygen can get in from the lungs, and then that blood leaves the lungs and goes to the collecting chamber for the left heart, which is the left atrium. and the left atrium stores the blood for the next heartbeat for the left ventricle. It empties into the left ventricle, which then pumps the blood to the rest of the body, and that blood has oxygen in it. So one circuitry has blood without much oxygen, and the other one has blood that is full of oxygen and go into the brain and the tissues of the body, as well as the arteries of the heart itself.
Okay, so that's a great introduction. Dr. Goldberg, as a plastic surgeon, plastic and reconstructive surgeon, I'll often tell my patients that all tissue throughout the body needs a blood supply, and blood needs to come in, and it also needs to leave. Now, both of those, arterial system and venous system, those are really of paramount importance. So, once again, let's review. So it's the body, it's the job of the heart to pump blood to the lungs, where it's aerated and gets full of oxygen, and then it comes back through the pulmonary vein, correct?
Correct.
Into the, you said it's the left side of the heart.
The left atrium is the chamber.
Left atrium, and then that goes into the left ventricle, and is that the strongest pump in the heart of the four chambers?
That's right, because it has to pump blood not just to the lungs, which are next door, but to the brain, to the fingertips, to the legs, and it has to accommodate for exercise and pump more blood when somebody's lifting weights or running a marathon or trying to run from a lion or a tiger if they're in the wild.
Well, Dr. Goldberg, actually, something that has fascinated me, even through medical school, I wish I had found the answer, but maybe you can teach me. How is it that the heart knows when it's supposed to pump harder and faster? Like, what's the signal to tell the ventricle you need to pump harder or faster to deliver more blood? How does the heart know?
Well, that's an electrical phenomenon in part, because the electrical system regulates how fast the heart pumps, and they get clues, the electrical system in the heart gets clues from receptors in other parts of the body. So, for example, in our carotid arteries, there's a receptor that gives us an idea of how much volume is getting to that part. And then there are other ways of communicating to the heart that more blood flow is needed, and those are neurological in nature. But that's not my area of expertise, because I'm the plumber, not the electrician. So the electricians are going to be better to describe some of those mechanisms.
Okay, so I need to be like a general contractor, and I'm talking to the plumber about the plumbing and water system, right? And I'm going to talk to the electrician about the electrical system.
Yeah, you got to have a guy. You got to have your electrician guy, and you've got to have your plumbing guy, and I'm your plumbing guy.
Okay, I'm starting to get the idea, Dr. Goldberg. So let's go back to these chambers of the heart.
Right.
There are two atria.
Correct.
There's the right atrium and the left atrium.
Right.
And there are two ventricles. The right ventricle, which pumps blood to the heart, to the lungs, through the pulmonary artery, and it comes back to the pulmonary vein to the left atrium, right? And then from the atrium, it goes into the left ventricle, and then out the aorta. The aorta is like the big white pipe. Now, what I want to point out is that he's not just a doctor on TV. He's not just faking it and playing a doctor on TV. He's an actual doctor who's getting a call.
Yeah, that's right.
Right? I mean, this is television. This is not quite Hollywood, but it is Monterey. Okay, so there's four chambers to the heart. There's the two atria, and there's the two ventricles. Now, isn't it true that they're separated by valves? The atrium and the ventricle is separated by valves.
That's right. There are four valves in the heart. The valve between the right atrium and the right ventricle is the tricuspid valve.
Tricuspid valve, okay.
And the idea of this and all the other valves is when the right ventricle pumps blood, it directs it the correct direction and not to go backwards. So if the tricuspid valve leaks, then a lot of the blood from the right ventricle, instead of going to the pulmonary artery and the lungs, will go backwards into the right atrium and cause the whole system to back up. And if there's too much of that, then a person may have trouble getting the fluid from their legs to get back to the heart, and they may get swelling of their legs or edema if that valve doesn't work properly.
Okay, so, excuse me. So the valves help direct the flow properly
Correct.
to the proper direction.
That's right.
Now, so it must be very strong muscles in the myocardium, in the ventricles, isn't that right?
Well, yes, but the right ventricle is not nearly as strong as the left ventricle, so because it doesn't have to pump as much, and the lungs are not like muscles. So even if you're exercising, the lungs don't create that much more resistance to flow, whereas if your legs are working, they're causing some resistance to the blood flow, so the left ventricle has to be able to adapt and pump even stronger under those circumstances, whereas the right ventricle has a little bit of an easier time of it.
Okay, so if the valves are what we call incompetent, or they're not working properly, then the blood, when either ventricle squeezes or pumps,
Right.
the blood can go in the wrong direction.
Right. So there's a comparable valve between the left atrium and the left ventricle, and that's called the mitral valve. The term comes from the hat that a bishop wears, which is a mitre.
A mitre.
A mitre, and the valve shape looks a little bit like that kind of a shape.
Okay.
And so it's called a mitral valve.
So on the right side of the heart, that's what you call the tricuspid.
Right.
Tri and cusp in Greek
Right.
means three leaves.
Right.
So there's three parts to that. And then there's the mitral valve, which is in between the left atrium and the left ventricle.
And it has two leaves.
Two leaves, okay. Does anybody call it the bicuspid valve or not?
No.
No. Okay,
Bicuspid valve refers to something else, which is having to do with the aortic valve, which we haven't gotten to yet.
okay, so there are other valves
Correct.
besides the ones in between the atria and the ventricle.
Right.
So what are the other valves?
So the other two valves are between the ventricle and the aorta that is being supplied by it. So there's a pulmonic valve, which is between the right ventricle and the pulmonary artery, and there's an aortic valve between the left ventricle and the aorta.
Okay, perfect. So very briefly, we know in this amazing organ that we have, the heart, the myocardium, which is the muscle, and there's the valves, and there's the blood vessels that deliver blood to the heart itself. And we mentioned briefly the electrical system that helps control the pulse rate, etc. So we know that it's an amazing, wondrous structure organ. However, things can go wrong. And so we know that every one of those structures, for example, the myocardium, the muscle itself, can get too thin, it can get too thick, you can have an aneurysm, which is sort of a ballooning effect, and the valves can go bad, right?
Correct.
Or you can you be born with a bad valve?
Absolutely, absolutely. And there are some congenital conditions where one valve is too small and the other is too large, and they have to be dealt with if that occurs. You can be born with a valve that doesn't have the right number of cusps in it. So even though we don't call it the tricuspid valve, the aortic valve also has 3 cusps normally, but some people only have 2 leaflets, and then we call it a bicuspid aortic valve, and that can cause problems for people when they get to be about our age. Some people are born with a single cusp of the aortic valve, and if that occurs, then they're going to have problems when they're a child or a teenager. We can be born with abnormalities of these valves. But in addition, you can develop problems on the valve. So the aortic valve may, over time, start getting stiffer and stiffer and filled with calcium. And it's fairly common for elderly people to have a narrowing of that valve so it doesn't open properly. Even though they were born with a normal valve, by the time they're 80 or so, it may work very poorly, or it may leak and cause problems from leaking as well.
Okay. Well, Dr. Goldberg, I have a question from real life. When I went to high school, we had these stories of guys who got bad strep throat or scarlet fever.
Sure.
And then if untreated, then they got something that was called rheumatic fever.
Right.
And then one thing led to another, and 6 or 12 months later, they were having problems with the heart valve.
That's
Now,
correct.
is that a true? Are those true events?
Yes, that is absolutely true, although I think the time frame tends to be more than 6 to 12 months. It's actually many, many years. So if someone develops a strep throat, common strep throat, then they have a reaction sometimes. They can develop a reaction by the body to that streptomycin and have something called rheumatic fever.
Rheumatic fever.
And the healing for that can cause problems decades later. So one of the valves we talked about, the mitral valve, one of the problems that can develop with that is that it stops opening properly. And that's a very common problem in other parts of the world. It's fairly uncommon here, but that's a result of rheumatic fever as a child, but it may not show up until someone's in their 20s or 30s, and the valve doesn't open properly, so that the left atrium fills up with more and more blood, and blood doesn't get through that into the left ventricle to pump to the rest of the body. And that fluid that's in the left atrium can back up into the lungs. So those people can have shortness of breath because of fluid backing up in the lungs, or they may be fatigued because of inadequate blood flow to the left ventricle and the rest of the body.
I see. Okay. Well, Dr. Goldberg, I want to learn more about valvular disease, and I do want to talk for a few minutes about how you can actually repair these valves or fix them without making a big sternal incision or going through the ribs. But before I get to that, now when we talk about a hole in the heart, or someone says a patent ductus or atrial septal defect, etc., now that's not referring to the valves, correct?
That's correct. That is correct.
So that's another structural problem.
Correct.
Now, what's the problem there when there's a so-called hole between chambers?
Well, let's talk about the atrial septal defect that you mentioned. The septum is a fancy word for the wall, and so between the right atrium and the left atrium, there is a septum, a wall between them. And if there's a hole, then those two parallel circuits no longer are working independently, but blood is going back and forth and corrupting the blood flow. So if you may go skip the lungs and go into the left atrium and not get enough oxygen, or it may come back through that hole into the right atrium, and now the right atrium and right ventricle has to work doubly hard because the right ventricle keeps pumping blood to the lungs, which then comes back to the left atrium, and instead of going to the left ventricle is now going back to the right atrium. So now the right heart has to work doubly hard to do its job, and it may not do it so efficiently that way. And one of the problems with having a hole there is that it turns out we may develop little tiny clots in the veins in our legs that can go up through the bloodstream. And if there's no hole, then those little tiny clots are filtered by the lungs and don't seem to cause problems. Now, big clots to the lungs is a problem, but little tiny ones is just the lungs will act as a filter. But if there's a hole in the atrium, then those little clots can actually get through that and gain access to the arteries of the body, because it'll go into the left atrium, to the left ventricle, and now those clots can go to the arteries of the brain and be obstructed and cause a stroke.
I see.
So this is a possible mechanism of a stroke in a young person who doesn't have the typical diseases of an elderly person who is prone to a stroke. So, and there are two versions of that type of hole in the heart. One is that there's a real hole in the heart, that someone's born with a hole in the heart, which is not that uncommon. And the second is that they just have a variation where it's not a hole but a flap, because there can be a flap of tissue on one side overlying a flap of tissue there. And we all have that when we're born, because when we're born, the lungs don't work in the uterus, right? So, and a more efficient way for the heart to work is for blood to get to the right atrium and then pop through into the left atrium and then the left ventricle, so that the right ventricle doesn't have to pump against lungs that are not working. So we have that. This is called a foramen ovale. Foramen means passageway. Ovale means it's oval. And patent is what we call it when it can be opened. Now, when we're born, the pressure gets higher in the left heart, left atrium, than the right atrium. So this tissue gets closed by that pressure differential. And by about 2 years of age, the tissues fuse in most people. But in a certain percentage of population, they don't fuse. And if they don't, if one of those little clots comes up there, it can actually get through there and cause a stroke in a young person. And one of the most important causes of strokes in young people is this patent foramen ovale. But a patent foramen ovale is very common. 10 to 25% of adults will have a patent foramen ovale. So most people, you don't need to worry about. But if someone does have a stroke, then we have to think about maybe closing that so that they can't have that passageway anymore.
I see. And now, do you have ways to repair those persistent openings without a big sternotomy and without
outpatient procedure? We can do it, and the patient can go home the same day.
Incredible.
Yeah.
Well, Dr. Goldberg, I'm going to need to ask you to come on the program again, and I hope we can make some time. But in summary, give me an introduction to how you can repair a valve or even replace a valve without a big operation. Now, I would like to say it hasn't been that long since I went through general surgery training and cardiac surgery training before I went into plastic surgery, where to replace a valve or work on a valve, we had a big opening. We opened the sternum, or we spread the ribs apart, and we actually got into the heart, and there were 2 surgeons, and we had 4 hands in there, like sewing and like sophisticated seamstresses. So now, this is amazing. You have ways to work on the valves without a big incision. Is that correct?
That's correct.
Just in summary, give me an introduction. I need to have you on the program again so I can learn more about this.
Well, the simplest way to explain this and understand is that we take advantage of the natural highways in the body that go to the heart and vascular system, which is the arteries and veins. So we go through those arteries and veins to get to where we need to and repair the problem that exists. So we said that the veins go up to the right atrium. So if we want to treat something that is in the vicinity of the right atrium, we can go through the veins of the body and get up to that space. We can go through the arteries of the body to get to the left heart to treat things. So I talked about atrial septal defects and patent foramen ovale, or we abbreviate PFO. How do we do it? We go through the vein in the groin, which is very near the skin surface. Simply numb up the area, put a needle into the vein, change that out for a plastic tube, and now we can go through these structures without any discomfort to the patient. They can be wide awake and often are. We can go up to the hole, and we have technology which will allow to plug those holes.
Well, Dr. Goldberg, I hope this is not too basic a question, but how is it that you can see, and how can you tell what you're doing if you're making a little incision in the groin or the femoral vein? How is it that you can see what you're doing, or how do you know what you're doing up in the heart?
Well, we have different technologies which allow us to visualize through the skin. X-ray technology allows us to do that. Ultrasound technology allows us to do that. And so we take advantage of these different technologies both during the procedure as well as before. So we'll sometimes use a CT scan to help us guide what we want to do. And during the procedure, we'll use X-ray imaging to see where we're at, as well as ultrasound imaging to be precise at what we're doing.
Well, Dr. Goldberg, this is incredible stuff. I'm not ready to leave plastic surgery because I love plastic surgery, reconstructive surgery, but this is fascinating. I'd love for you to come on the program again.
Sure, it would be my pleasure.
Dr. Stephen Goldberg, you're now with the Montage Community Hospital Cardiology Group right here in Monterey, California. Please come on the program again. Dr. Stephen Goldberg. Thanks very much.
Thank you very much. I appreciate it.
Once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon here in beautiful Monterey, California. This is the Doctor is in Television program. We're going to take a very brief pause for a very good cause. I hope you stay with us.
It's scary making the decision to have reconstructive surgery, but it's so worth what you get out of it.
I'm stress-free. I know I'm not going to get breast cancer.
Everything is back to normal, and it really did not take long to bounce back.
I have a sense of hope for other women that this surgery can help them to live normal lives.
This year, more than 200,000 women in this country will be diagnosed with breast cancer. For many of them, a mastectomy or removal of the affected breast will be recommended as part of the cancer treatment.
The idea of losing a breast for some women can be almost as difficult as being diagnosed with breast cancer. Modern breast reconstruction can help. The purpose of this presentation is to provide women with valuable information about the major issues in breast reconstruction.
We'll have an opportunity to speak with women who chose different methods of reconstruction. We'll talk to experts in the field of breast cancer, and we'll let you know your options for breast reconstruction.
I embraced the mastectomy and reconstruction procedure, and because of that, I had a terrific outcome, and it's changed my life in a positive way.
For the thousands of women who will be diagnosed with breast cancer this year, we understand this is most likely a troubling and frustrating time. We hope this presentation's been valuable to you and will help you make some very difficult decisions that you're facing.
Welcome back to the Doctor is in Television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California. Thank you very much for joining us for the Doctor is in Television program. Well, I'm delighted I was able to convince Dr. Stephen Goldberg to do another segment. We're learning about the heart and the 4 chambers of the heart and what the valves are and how problems can persist and things that go wrong, and most importantly, how he fixes things. So Dr. Goldberg, let's review. So we know there's 4 chambers of the heart. There's the 2 atria. There's the 2 ventricles. You taught us that the left side of the heart is responsible for pumping blood out to the body, and the right side of the heart, in summary, is responsible for pumping blood to the lungs so we can blow off CO2, breathe out CO2, carbon dioxide, and then get oxygen back in and redistribute it, etc. So we're talking about valves that are in between the atria and the ventricle, and there's also, you taught us, there's a pulmonic valve and there's an atrial valve.
Aortic valve.
Aortic valve, of course. And that those valves can be scarred, they can wear out, they can have congenital problems, and you have ways that can fix those valves, repair them without making a big huge sternotomy or going through the chest wall or through the ribs. You have ways to do that.
That's correct.
So let's talk about perhaps the most common approach for valvular disease that you repair. What's the most common valve that you repair or not replace but fix?
Well, the one that has really made a big impact in the last decade has been the aortic valve. Your question is a little bit hard to answer because that's the one we know how to treat very well right now, but it's not the most common valve problem. The more common valve problem is the mitral valve, but we aren't as far along in terms of established therapies for that as we are with the aortic valve.
Okay. Well, Dr. Goldberg, of course, every time you talk, it's great, but then I have 100 questions. So you talked about the mitral valve. We hear this phrase a lot, mitral valve prolapse. And sometimes I hear, oh, it's a terrible condition, and other times I hear, oh, it's nothing to worry about. 20% of women have mitral valve prolapse, or then they shouldn't worry about it, and then they worry about a heart murmur. So teach us about mitral valve prolapse, if you can, in summary. Is it a problem or not a problem?
It is a problem, but it's a rare problem, and it was overdiagnosed dramatically about 20 or 30 years ago, and partly because the complexity of the mitral valve, it really is a horseshoe, not shoe, a horseshoe, but a saddle shape. A saddle shape, and so there's kind of different curves and, well, imagine a saddle is not a simple round structure. And when we started doing ultrasound imaging, depending on how that saddle was sliced, it looked like some of the valve leaflets were going back into the left atrium more than they should have. But then people, and that's what we consider to be mitral valve prolapse when it goes back or prolapses into the left atrium. But then we realized that that was just an unsophisticated way of looking at the mitral valve, and that we see that characteristic all the time in completely normal valves. There are some people who have a distinctly abnormal valve, and those leaflets will go back into the left atrium, but it's only a problem if there's significant leakage into that. So it is rarely a problem. There are some people that have it, but the diagnosis of mitral valve prolapse tends to be overused. And so that's why it seems like most of the time you hear it's not a problem.
Okay. Okay. So back to the ranch, as we
Sure.
said, you started talking about the aortic valve.
Right.
Probably that's the most commonly treated valve in interventional cardiology.
Correct.
Is that correct?
Correct.
Okay. So give us a summary. Give us a capsule version of how you get to the aortic valve and what you can do with it.
Well, let me explain why. First of all, I mentioned before that one of the common ways for the aortic valve to cause problems is because of during life it starts getting more fibrotic and calcified, and the older we are, the more that occurs, such that in people who are born with a normal valve, when they get into their 70s, 80s, and 90s, that valve may not work just because of the full life that they've lived has caused problems on the valve. And so these are people that are now suffering because the valve doesn't open, so the fluid backs up to the lungs and they get short of breath, or it doesn't get to the rest of the body, so they feel fatigued, or they may even pass out because they don't get enough blood flow to their brain. But because they're older, it's a little riskier, or a lot riskier, to try and do the traditional treatment, which is to open them up, open up their chest, take out the old valve and sew in a new valve, which is a very, very effective surgery, but many people are just not good candidates because they're just not good candidates for open heart surgery. In fact, a high percentage of people with symptomatic problems with their aortic valve can't because they're maybe too old or they have other problems that they've developed along the way. So it was recognized that there was a value of trying to find a way to treat these valves, usually that they just don't open properly, and that we call aortic stenosis. So to treat this condition without requiring a patient to undergo open heart surgery. So the way we do it is, we use the highways that the body provides us, which is, in the case of the left heart, for the aortic valve, is the arterial system. So again, we find an artery in the groin area, which is close to the skin. We numb up, we put a needle in, we put plastic tubes in, and through these plastic tubes, we're able to go all the way through the aorta, across that valve, and now we have a pathway to deliver equipment. And one thing we can do is put a balloon across that valve and inflate the balloon and crack the valve open.
Incredible.
Now that is incredible, but it's not that effective. Sometimes it works somewhat, but not reliably. So now the next step is to put a valve, a piece of metal called a stent, on that balloon, and inside the stent is sewn in a valve. So now we go across into that valve. We inflate the balloon, which has the stent on it, which opens up. And when we deflate the balloon, now there's a functioning valve. Now there's other ways of doing it that don't require balloons, where you just put a tube across the valve and you pull the tube back carefully, and there's a self-expanding piece of metal that has a valve sutured inside of it. And so that's another alternative. Both of those are FDA approved and very successful approaches in treating this condition. And now we're able to treat a lot more people than the surgeons were able to before. And we're now able to offer it to people who maybe aren't such bad surgical candidates as well, but they're able to have this procedure and have a shorter recovery and a less significant recovery because they don't have their chest opened up.
Well, Dr. Goldberg, that's fascinating. Now, just in summary, I only have about a minute or two. So let's talk about the mechanics of it. When you work on that aortic valve, you slip in through the femoral artery, is that correct? So that's you numb up the femoral area, that's in the groin crease, you numb that up, you can dissect down and get to that femoral artery. Now, is someone asleep? Are they awake? Is it outpatient, inpatient? They stay overnight? Are they under general anesthetic?
Traditionally, it was done under general anesthesia, and they would be asleep for it. But now there's a movement more and more towards doing many of these under local anesthesia with just a little bit of mild sedation because it's probably anxiety provoking to be lying on a table having somebody work on your heart. So you just give them a little something to relax and you can do the procedure. Most people will watch them at least overnight, if not for a couple of days, but there are some places in the world that are starting to do this as an outpatient.
This is incredible.
Yeah.
Dr. Stephen Goldberg, board-certified cardiologist here at Community Hospital, Monterey Peninsula, the Montage Medical Group. I want to give out some phone number or website or something. I know the hospital operator number. Is that good enough, or is there a number? Or well, I'll try that.
I have a card in my pocket. I can look that up.
You're so new here.
I am.
Community Hospital, Monterey Peninsula, right here in Monterey, California. 831-624-5311. Get connected to the Heart Center. Dr. Stephen Goldberg, I appreciate you coming on. Please come on the program again. I learned a lot, and
I'm honored to be here, and I enjoyed it very much.
It's been great for me. Once again, this is the Doctor is in Television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here in Monterey, California. Please stay with us. We're going to take a very brief pause for a very good cause. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline.